Hello and welcome back. We're so close to wrapping up the CCVR lessons. This video provides you a brief overview of Lesson 10, the role of our eyes in dizziness and balance. For this lesson, I provide you a key summary based on the original content from physical therapist Natasha Johnson, who has her Certificate of Competency in Vestibular Rehab and is board certified from the Neuro-Optometric Association, or NORA. I also add information about practical anatomy and physiology of the visual system and provide insights from neuro-optometrist and current NORA president, Dean Fitzgerald. For this lesson, we drive home the message that the eyes are more than just what we see, but how does the brain perceive this information? How well do the eyes work together? It's an essential part of an exam in those with dizziness and balance disorders. As I mentioned in a previous lesson, oculomotor activities may not be a part of vestibular rehab, but will be a part of your assessment and are an integral piece to our rehab care plan. Although the neck, the visual system, and vestibular share intricate pathways, we can perform different tests to bring insights into what system, or in most cases, systems, are contributed to a patient's symptoms. It is estimated that 80 to 90% of what we see is processed through our cognitive centers. Thus, oculomotor impairments or eye misalignments can impair our cognition. As you may have experienced, vision training or vision rehab can be controversial, especially in the ophthalmology versus the optometry world. Remember, vision is a skill, and we rely on neuroplasticity to improve skills. Let's talk about the ocular motility exam. This is more than just the H pattern. You want to look at pupillary light reflex test. It's considered a motility test. Essentially, how well do the pupils respond to light? Do they have full range of motion per the 8 cardinal gaze test? And is there a difference between each eye? How is their eye alignment? Exo versus eso, hyper versus hypo. How does monocular viewing versus binocular viewing affect eye alignment? In other words, is it atropia or aphoria? In exo, the eyes are aligned towards the lateral aspect, as if the eye is trying to exit the building. In eso, they're aligned more inward towards the nose. Hyper is when one eye is higher than the other, or hypo is when one eye is lower. Is this caused by a nerve palsy or a skew deviation? Are the cranial nerves intact? Cranial nerves 2, 3, 4, 6. What's the combo of 3, 4, and 6? Which is what you're examining in the H pattern. Are there pathological findings in smooth pursuit or saccades? As a reminder, pursuit has high sensitivity, while saccades has high specificity. Additional exam considerations could be normal physiological diplopia. So normal physiological diplopia is when you look at the target you're viewing, it should be single, but a target in the background would be double. Or when you shift your gaze to the target in the background, it should become single, and the target close to you would be double. Assessing this is important before you implement Vergence exercises. We don't want to just jump to Brock string, especially if someone doesn't have normal physiological diplopia. This can actually be turned into an exercise. The visual midline shift test. It can be helpful if someone presents with Pusher syndrome or has a feeling of tilting. The subjective visual vertical test. It's been identified as a reliable test of otolith dysfunction. Other tests assessed in this lesson are the contrast sensitivity test, the confrontation field test, and the optokinetic nystagmus test at bedside. It doesn't mean you'll be doing all of these tests. You'll utilize your clinical reasoning skills to see what test brings you the most insight. For instance, let's talk about some additional differential special tests. Let's think about smooth pursuit. You'll start them with the head in neutral and they move their eyes, and you can compare that to the VOR cancellation test, which is a higher level demand of smooth pursuit. This is when the eyes, head, and body rotate and block together while tracking an object. We're assessing two things. How well can the eyes stay on that target without saccadic intrusions? If they're unable to do that, it indicates cerebellar dysfunction. Or maybe you're using this test as a motion sensitivity test. So there's smooth pursuit with the head in neutral, smooth pursuit per the VOR cancellation test, and smooth pursuit torsion test, where you're repeating the smooth pursuit test with cervical rotation, trying to identify if there's a cervical component. Then there's the head-neck differentiation test. So think about VOR times 1, where you're rotating the head on the body. Or maybe you stabilize their head while they're sitting on a rolling stool and they rotate their body. Other important differentials are superior oblique palsy versus trochlear nerve palsy versus skew deviation. We also talk about the pathological ocular tilt response. There's 3 components to that. We have a physiological ocular tilt response, which is a normal response, versus pathological. There's 3 components to the OTR. You're looking at head tilt, a skew deviation, and an abnormal torsion of the eyes. Then we talk about treatment strategies. Dr. Fitzgerald shares her philosophy, vision vestibular rehab strategies, and a logical order of treatment, starting with fixations, then pursuit, saccades, on divergence and accommodation, add a cognitive load, vision and vestibular integration, progressing that into movement and body awareness. And these are often done simultaneously. Natasha shares how you turn impairments from the exam into the interventions. Maybe you start with ocular stretches or eye range of motion exercises. Address any impairments with normal physiological diplopia, especially before doing something like Brock string. Common exercises may be stick in a straw or stick in a tube, with the progression to Brock string. You can use these for ocular stretches, saccades, then vergence. We talk about using stimulation in the periphery because we want to avoid that over-usage of staying in our central visual field. We want to be aware of suppression. So when you are doing Brock string, does that string make an X or does it make a Y? If it makes a Y, they're suppressing one eye. I share some of my favorite go-tos. Ocular range of motion. I love binocular occlusion, or BNO, where you tape the nasal side of glasses. This is to promote movement of the eyes into the periphery for peripheral central integration. I too believe we have to address any impairments with NPD before working on convergence with binocular viewing. I love central peripheral integration exercises, while you have a central task while also doing something in the periphery. One more lesson in the CCVR course, and this is special topics, and man, do we cover a lot of topics. Pediatrics to the aging adult, functional neurological disorders, persistent postural perceptual dizziness, or 3PD, Maladé-Department syndrome, or MDDS, visually induced dizziness, visual motion induced dizziness, dizziness in the litigating patient, catastrophization versus rumination versus perseveration. There's a lot of great stuff in that final lesson plan. So stay tuned and thanks so much.